Hello, I'm Dr. Rita Dadiz from the University of Rochester. In this module, I will discuss the management of RDS. The learning objectives are to describe the clinical strategies and therapies used to decrease the risk and severity of RDS, and to discuss the management of RDS, including surfactant replacement. The single most important intervention to decrease the risk of RDS is to prevent preterm delivery. When possible and not contraindicated, addressing underlying maternal medical conditions such as providing antihypertensive medications for preeclampsia is important to prevent preterm delivery. In addition, tocolytic medications can potentially stop or delay preterm labor. However, when there is a high risk of delivery, antenatal corticosteroids should be given to the pregnant woman who is less than 34 weeks gestation to help accelerate lung maturation. In a clinical trial published in 1972, ligands found that betamethasone given to pregnant women in preterm labor between 24 to 36 weeks gestational age decreased the incidence of RDS and neonatal mortality. Since then, other studies supported the beneficial effects and safety of corticosteroids, and in 1994, the NIH recommended the administration of antenatal corticosteroids to pregnant women who are at high risk of delivering a preterm infant at less than 34 weeks gestation. Antenatal corticosteroids have been shown to accelerate lung maturity, thereby reducing the incidence and severity of RDS. Steroids have also been shown to reduce intraventricular hemorrhage, necrotizing enterocolitis, and neonatal death. The current recommendation is a 2-dose course of betamethasone given 24 hours apart. An alternative regimen is a 4-dose course of dexamethasone given 12 hours apart. Studies show that both medications are effective over placebo. However, betamethasone may be more efficacious in decreasing RDS. In addition, betamethasone is associated with decreased intraventricular hemorrhage due to induced vascular stability of the germinal matrix and periventricular leukomalacia. Steroids are effective if given within 7 days of delivery and most effective within 24 to 48 hours of delivery. A second course may be considered if there is a high risk of delivery and it has been greater than 7 days since the last course. However, judicious administration of multiple courses of steroids is important because it has been associated with fetal growth restriction. If preterm delivery cannot be prevented, then healthcare providers should monitor infants born prematurely for signs and symptoms of RDS. A chest X-ray should be obtained in infants with respiratory distress to assess the lung fields to evaluate for other potential causes of respiratory distress. Management is supportive, providing positive pressure ventilation, monitoring oxygen saturations with pulse oximetry, and obtaining vascular access for anticipated frequent blood gas monitoring, hydration, and assessment of blood pressures. Blood transfusions may be necessary to improve oxygen delivery, and antibiotics are usually started because classic findings of RDS on chest X-ray can be indistinguishable from group B streptococcus and other forms of congenital pneumonia. If an infant born preterm manifests with signs and symptoms of RDS, the treatment may include surfactant to improve ventilation and oxygenation. Infants born at term with respiratory failure also would be candidates for surfactant if they have conditions that predispose them to surfactant deficiency or inactivation, such as maternal diabetes and meconium aspiration. In 1990, the FDA approved the use of surfactant in infants. Studies show that surfactant decreases the incidence and severity of RDS by improving oxygenation, functional residual capacity, and lung compliance within 1 hour of administration. As a result, gentler use of positive pressure ventilation decreases the risk of developing a pneumothorax and pulmonary interstitial emphysema that are associated with barotrauma and volutrauma. Ultimately, surfactant reduces the mortality associated with RDS. Surfactant has an additive effect when infants have been exposed to antenatal corticosteroids. While surfactant reduces the risk of developing pulmonary air leaks, pneumothorax is a known complication when positive pressure ventilation is not reduced, as lung compliance improves rapidly after surfactant administration. In addition, pulmonary hemorrhage may occur because of improved lung compliance that leads to an increase in left to right shunting through the patent ductus arteriosus, increased pulmonary blood flow, and pulmonary congestion. There are many considerations in the administration of surfactant, including the type of surfactant, the timing of administration, and the number of doses. There are both natural and synthetic preparations. Natural porcine or bovine surfactants contain phospholipids and surfactant proteins B and C, which facilitate the adsorption of phospholipids on the air fluid interface inside alveoli. Clinical trials have shown that the administration of natural surfactant, when compared with synthetic products that contain only phospholipids, results in a more rapid response in improving oxygenation and ventilation, as well as a decreased rate of pneumothorax and mortality. When compared with synthetic protein analog products that mimic surfactant protein B, there was equivalent efficacy and non-significant differences in morbidity and mortality. Surfactant is administered endotracheally. Other modes of administration, such as nebulization, aerolization, bronchial alveolar lavage, and laryngeal mask airway, have either not been effective or need additional data to investigate its safety and efficacy. A dose of surfactant is usually administered in 2 or more aliquots. There is no standard recommendation on how to position the infant during administration, nor when the infants should be adjusted with different aliquots to facilitate administration of the medication to different parts of the lung. A single exogenous dose increases the infant's surfactant pool. However, additional doses may be necessary, depending on the severity and amount of ventilation support required, because the proteinaceous exudate that results from RDS-associated lung injury inhibits surfactant function. The timing of administration has been an ongoing topic of discussion. Prophylactic surfactant administration within 30 minutes of birth has the advantage of increasing the infant's surfactant pool to improve lung compliance and functional residual capacity before too much lung damage occurs. However, when surfactant is given prophylactically, infants may be unnecessarily intubated, mechanically ventilated, and given the medication, especially in older infants with more advanced lung maturity. In contrast, selective early or late surfactant administration as a rescue therapy occurs after RDS has clinically manifested. While less infants are treated and surfactant administration occurs in a more controlled environment outside the delivery room, inflammation and alveolar wall damage may have already progressed. With these considerations, prophylactic surfactant may be most beneficial in infants born below a certain gestational age to balance the risk and benefits of administration. Given the discussion around the timing of surfactant administration, there have been studies such as the 2010 support trial and meta-analyses that examined whether preterm infants should be given prophylactic surfactant or placed on continuous positive pressure ventilation or CPAP to improve their functional residual capacity. CPAP as a treatment modality helps to stabilize alveoli, maintain an infant's functional residual capacity, and improve oxygenation. With adequate FRC, intrapulmonary shunting is minimized, thereby optimizing gas exchange. These studies showed that it is reasonable to consider foregoing prophylactic surfactant in infants who can demonstrate appropriate respiratory effort in the delivery room without progressive respiratory failure, and, if needed, providing selective early surfactant administration. In 2014, the American Academy of Pediatrics Committee on Fetus and Newborn recommended that healthcare professionals consider the use of CPAP immediately after birth with subsequent selective surfactant administration as an alternative to routine intubation with prophylactic or early surfactant administration in preterm infants. In addition, infants who need mechanical ventilation because of severe RDS should be given surfactant after initial stabilization. Additional research is needed to better characterize the subset of infants born less than 30 weeks who may or may not need surfactant. In summary, in this module, we discussed the management of RDS, including the prevention of preterm birth, the use of antenatal corticosteroids, surfactant replacement therapy, and the use of continuous positive airway pressure. I hope you enjoyed this module. For more information and to further your learning, I recommend you read the suggested articles and discuss the cases in the student guide with your facilitator and colleagues in an upcoming group session. In addition, for more in-depth information about surfactant and CPAP, please search for the separate educational programs on surfactant and non-invasive ventilation strategies in Minute CE. This concludes this module. Thank you.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.